and he is also in charge of ECMO services in Apollo Multispeciality Hospital. Is a primary investigator of lot of trials, and also he has a lot of publication in national and international publication, and he's a very good orator speaker. So Chandashis, I will request you to enlighten us with the news and new update on ventilated associated pneumonia. You are the best person on this
Thank
topic.
you. Thank you, Dr. Asif. Again, I want to thank Dr. Asif and all of you for inviting me to this seminar today. It's my privilege to talk on a topic which is a problem often faced by both critical care physicians as well as pulmonologists, that is ventilator-associated pneumonia. Obviously, it's a pretty big topic, and Asif has not specified on any particular aspect of the discussion. So I will try to give a very short overview about VAP. And although it is within the section of fungal pneumonia, but I'll basically be talking on an overview of VAP, and of which bacterial infection is the most common. I have seen that there is further talk on fungal pneumonia by other very distinguished speakers, so I will not enter into that zone. Now, the first, so in VAP, which is ventilator-associated pneumonia, we are going to primarily discuss about, in the next maybe 15 minutes time, we are going to discuss about the areas which are more controversial, or we have doubt regarding what to do and what is the best thing. Now, first is, although we all know that patients who are on the ventilator for more than 48 hours and has now developed a pneumonia is supposed to be categorized as ventilator-associated pneumonia. The question arises, how do you decide when, if the patient already was intubated and ventilated for a community-acquired pneumonia, maybe a viral pneumonia, and how do we understand that this patient has now started developing a different kind of pneumonia, which is a ventilator-associated pneumonia? Or is it the same community-acquired pneumonia which is worsening? This is something which becomes a problem for us. Not much of a problem in patients who are ventilated for different other reasons. For example, a neurosurgical patient who is ventilated for a poor mental status because he cannot maintain the airway, or a surgical patient who is maybe ventilated for an abdominal surgery which went on for a long time with a significant fluid shift and blood loss. Here also, it becomes difficult to understand that if the patient is worsening after 48 hours and the oxygen requirement maybe is going up, how do we know that this is a ventilator-associated pneumonia? Or is it an ARDS which is happening because of worsening of the intra-abdominal condition, or maybe an intra-abdominal sepsis which is causing an extra pulmonary ARDS? So the definition, although it's on the face, it looks pretty simple. For us who do it on a day-to-day basis, it becomes difficult to figure out, is it a VAP or is it not? So to diagnose VAP, a few things are necessary. Obviously, you need a clinical scenario. That means the patient's clinical condition must have worsened. The patient's ventilator requirement, either in the form of ventilation or in the form of oxygenation must have worsened. Patient's clinical conditions are supportive of infection, which means there is fever or hypothermia, there is leukocytosis or leukopenia, there is profuse purulent secretions, there is new infiltrates on the chest X-ray, which again are very, very difficult to differentiate because infiltrates don't tell us whether these infiltrates are infective or non-infective. And with this clinical scenario, if we find that there is growth of microorganisms in materials taken from the endotracheal tube, and this patient is already on ventilator for more than 48 hours, and the microbe that we are growing in the lab looks typical of microorganisms that are isolated in this hospital about which we are talking as a common nosocomial infection, then putting it all together, we try to diagnose it as VAP. The first question that comes is regarding collection of this sample for culture. From where are we supposed to collect this culture? Is it from the proximal airway with a more non-invasive technique? Or to simply put it, is it an endotracheal secretion which must be sent, which usually is just with the help of a catheter put down into the endotracheal tube and then taking it out. Sometimes you can do it in a more protected way, which is you can put a catheter within a tube and put the whole thing inside. And once you are significantly inside the trachea, the inner catheter will be pushed out to collect the sample and then pulled back into the outer tube, and then the whole thing comes out. But both of this is categorized as a non-invasive proximal airway sampling. The other is a more invasive method of sampling, which is basically a bronchoscopic valve. Or a mini valve. Most of the time, we don't do a proper lavage in the ICU because a lavage needs a lot of fluid. Usually, a significant volume of fluid should be given to do a lavage. So what we usually do is better described as a bronchial wash because patients are unstable. They do not tolerate bronchoscopy for that long. And we really don't want to make the lungs so soggy with fluid. And in favor of the bronchoscopic valve, there are certain organizations, mostly Europeans, who favor it to diagnose VAP. And their logic is if there is a bacteria growing in the valve fluid, then you are kind of sure that this is the bacteria which is causing the infection because you have done a distal sampling. The chance of colonization is much less, provided your bronchoscope itself is not contaminated. And it will help to cut down unnecessary use of antibiotics because you are not going to treat the tracheal colonizers. And the organizations which are in favor of this are the European Society of Intensive Care, the European Society of Microbiology and Infectious Disease, and the European Respiratory Society. On the contrary, across the pond, the Americans, which is the American Thoracic Society and the Infectious Disease Society of America, are in favor of a much less invasive technique. They think that if you do a proximal sampling from an ET suction, that is good enough, and it does not there is a Cochrane review published in 2014 that as far as mortality is concerned, it does not matter whether you take a proximal sample or a distal more invasive sample because it does not cause mortality difference with bronchoalveolar lavage. Now the cutoff for quantitative cultures, we are all in favor of quantitative cultures, whether it's proximal or distal. And if you're doing it a BAL or a mini BAL, a 10 to the power 4 CFU per ml is significant. If you're taking a protected specimen brush, then 1000 CFU per ml is significant. And if you are just taking a proximal non-invasive sampling, then 10 to the power 6 CFU per ml is significant. However, whenever you are judging endotracheal sample, which is non-invasive proximal sample, we must look at the Q score. The Q score is provided by a microbiologist, which tells us that how is the sample like? Is it more of, if it contains a lot of epithelial cells, then it probably is a poor sample, and it is not representative of the lower respiratory tract secretions. The sensitivity of endotracheal secretion is highest, but the specificity is lowest. And this is opposite for bronchial or alveolar lavage or PSP, where obviously the specificity is much higher. The sensitivity is, however, lower. What it basically means is that if you are sending a proximal sample, and if you are growing, let's say, Pseudomonas, it is possible that the same Pseudomonas is causing the VAP, or it is possible that this Pseudomonas is just a colonizer and not causing the VAP. However, the chance of isolating the Pseudomonas becomes much higher. On the other hand, if you are doing a BAL, and if you have not taken the specimen from the right bronchopulmonary segment, which is consolidated or which is harboring the pneumonia, then you might completely miss the bacteria and you may not grow anything. But if you do grow Pseudomonas from this BAL sample, you are very sure that this is causative of the VAP and this is not a colonizer. So that is the difference. But the chance that you're going to miss this Pseudomonas altogether is higher than just taking a proximal sample. The evidence is in favor of BAL or mini BAL to decrease antibiotic use, duration of antibiotics, and superadded infections. And just like Europe, in India also, the trouble and the problem of multi-drug resistance is high. The problem of superadded infections is high. And we all want to decrease the antibiotic load and the antibiotic exposure of the patient. And therefore, we may err on the side of doing a more invasive sampling. However, as far as the mortality is concerned, till now, the evidence is that it doesn't make a difference whichever way you sample the airway. There's a little old data, but somehow has remained more or less the same as far as ventilator-associated pneumonia is concerned, and kind of represents the bugs that are grown in respiratory samples of ventilated patients from almost across India or even Southeast Asia. And the major players, as you can see, are all gram-negatives, Klebsiella being the most common in this, and Acinetobacter, and then you have Pseudomonas and E. coli. And these sectors may vary a little bit from hospital to hospital. In some hospitals, the Pseudomonas is more, and in some hospitals, the Acinetobacter is more. In our hospital, we are troubled most by Klebsiella. Other than that, there are certain species which often come, particularly in patients who have been in the hospital for quite a long time, like Proteus, Providencia, Barkholderia, Elizabeth Kingia, Serratia, etc. And these are patients who have been exposed to drugs like colistin, because most of these organisms are resistant to colistin. And therefore, these are what we call breakthrough bugs. Breakthrough bugs means that these grow when the patients are receiving carbapenems and colistins, because many of them may be resistant to colistin. We are particularly at a problem when bacteria like Proteus or Providencia are resistant to carbapenems as well, because our options become very less to treat these bacteria. Staphylococcus, which is gram-positive, as you can see in this cartoon, is kind of rare in our hospital and in most hospitals of this city and in most hospitals of this country, particularly in the private sector. Government hospitals, the data is also kind of similar as far as I'm aware, but Staph aureus is low. So it's around 5%, and it's never more than 8% in most of the hospitals. So the general rule is when we try to cover for microbes with the help of empirical antibiotics, we try to cover for more than 80% of the bugs. And in that sense, we may be okay if we do not cover for Staph aureus, because it's only 5% here. And therefore, you may not need, theoretically, you may not need a MRSA cover. Now, these are sensitivities of Acinetobacter, and as you can see, the over the years, in one point of time, maybe I'm talking about the year 2006 and 7, most of the Acinetobacters we could treat with cefoperazone sulbactam. Now, the sensitivity has dropped to as low as 13%. And then we were treating Acinetobacters with carbapenems and sometimes with aminoglycosides. But now the sensitivity of carbapenems have dropped to as low as 3%, gentamicin to 7%, netilmicin to 19%. So we are all left with colistins and polymyxins. In certain group of patients, it will be sensitive to the cyclines, which is the doxycyclines and the glycyl cyclines like the tigecycline or minocycline, which has been much later introduced. Unfortunately, in our center, the sensitivity of minocycline is not very good. It varies between 30 to 40%. Doxycycline is also around 30%. Tigecycline is around 70%. So these are things which we often combine for Acinetobacter. Remember that if you're using it for blood, minocycline may be slightly better than tigecycline. If you're using it for the lungs, that means the infection is, the Acinetobacter is not growing in the blood as well, then you may be using tigecycline, but you need it at a higher dose, which is 200 milligrams a day. And again, if you're using minocycline, you might, it is better if you use it at a higher dose, provided the creatinines are normal, which is around 400 milligrams a day. And doxycycline is usually used in the normal dose. So 97% of our Acinetobacters are multi-drug resistant or pan-drug resistant, some XDR, that means extremely drug resistant. Now this is Klebsiella, and Klebsiella has a variable this thing, but as you can see, if you're using empirically carbapenems for Klebsiella, most of the times it is very disappointing. The sensitivity is less than 30% now. This is 2015. In 2020, it's less than 30%. Sometimes Klebsiella is still sensitive to some of the aminoglycosides, like amikacin. It can remain sensitive is more than 50% cases. It can also remain sensitive to certain drugs like chloramphenicol, cotrimoxazole. Obviously, colistin and polymyxin B remains the backbone. And sometimes, again, it will be sensitive to doxycycline, tigecycline. 84% of these bacteria are ESBL, and 65% in our center is multi-drug resistant. Now, recently there are a new class of drugs which has been introduced, which is the newer BLBLIs. So these are all BLBLIs. In the first three are all BLBLIs. That is amoxicillin clavulanic acid, cefoperazone sulbactam, and piperacillin tazobactam. But all of them, as you can see, has got a pretty poor sensitivity for Klebsiella. But the newer BLBLIs, which is basically the ceftazidime avibactam, these drugs can show sensitivity towards Klebsiella if they are ESBL, if they are OXA strains, if they're KPCs, but not if they're NDMs. So that is a problem. But in our center, among Klebsiella which are resistant to carbapenems, we still find a good amount of OXA positive and ceftazidime avibactam sensitive. So in these cases, you might be able to avoid colistin. Pseudomonas is definitely the best of the lot. If we talk about the three trio of Acinetto, Klebsiella, and Pseudomonas, and obviously there are a little bit more option. Particularly, you can find ceftazidime to treat Pseudomonas. You can find piperacillin tazobactam to treat Pseudomonas. You can find the aminoglycosides to treat Pseudomonas. And obviously colistin and polymyxin B. Quinolones are not great drugs and do not use them alone. And if you're using ciprofloxacin, obviously you need a much higher dosage. Now the CDC definitions to diagnose VAP goes something like this. For the ventilator-associated events, there's a three-tier surveillance system which was started in 2013. The ventilator-associated condition is defined as an increase in FiO2 by 20% or PEEP by 3 over 48 hours. IVAC, which is infection-related ventilator-associated condition, is defined as fever or hypothermia, increased total leukocyte count, and addition of antibiotics over the last 4 days. Possible VAP, if there is addition of microbiology to VAC, that means if there is a growth which the microbiology reports, and these are these can be clubbed under any ventilator-associated event will worsen the outcome of the patient, which is evidence-based. But there is no such definition were found useful to diagnose VAP. And these are again only definitions used for surveillance purpose and not for clinical diagnosis. How will imaging help? Well, chest X-ray has been, most of the places it has been used to define VAP as newer infiltrate. But again, as I told you, chest X-ray are probably one of the worst modalities because it doesn't tell us whether these infiltrates are infective or not, unless there's a clear-cut lobar involvement which we see in a chest X-ray. And this is the rarest chest X-ray that we see when we are trying to diagnose VAP. So most of the time doesn't help. CT chest is definitely much better because we can see the air bronchograms, we can see the pattern of distribution, we can find pneumonia in more dependent portions, which is maybe retrocardiac or behind the heart in the chest X-ray, where it's difficult to figure out, particularly because the X-ray qualities are poor in the ICU. So CT chest will definitely be better, and as an imaging modality, it will probably score over chest X-rays many times to diagnose VAP. USG is also a good tool to diagnose pneumonia, provided you have the energy and you have the enthusiasm to scan each and every part of the lung to figure out whether there is air bronchograms, which you can see with the help of ultrasound. So what you see with an ultrasound is basically the PLAP sign, the shred sign, lobar consolidations, and dynamic air bronchograms. I will not go into the details of the ultrasound but these are things which we have to see. Posterolateral alveolar pleural syndrome is something that we try to see, particularly if we place two hands side by side, just below the clavicle. And if we can draw a line from the lower point of this hand, it will cut the posterior axillary line at this point and the scapular line at this point. And this is the point where you basically look for any shed signs or small areas of consolidation air bronchograms, etc., which are very often missed in the chest X-ray. So this is called a Plapp's point, or the pleural posterolateral alveolar pleural syndrome. Biomarkers, they're markers of doubtful benefit. The most commonly two used are the procal and the CRP. Most of the time, if the patient is having VAP, the CRP increases by day 4. However, CRP can increase because of infection anywhere else, so it doesn't tell you for sure that this is coming from a pneumonia. As far as procalcitonin is concerned, it is not recommended to measure procalcitonin if you are treating a VAP or pneumonia for around 7 to 8 days, because the only role of using procalcitonin is if your initial procalcitonin is high, and if you're following it every alternate day till the procalcitonin drops to less than 80%, and thereby reduce the antibiotic duration. However, if you are using it for anything less than 7 days, the benefit is so low versus the cost that it's not recommended. There are certain situations where you might have to use procalcitonin, particularly if you are treating the pneumonia over a longer duration of time, say more than 10 days or 14 days. And there are certain situations where you might have to do it. And these are conditions where procalcitonin may be useful. What about CRP and in bronchial lavage or STREM 1? And these have been mostly, I will say, mostly experimental and not really very useful in the clinical world. The CPIA score is very commonly used as a clinical score to diagnose VAP. And in recent meta-analysis has failed to, however, facilitate diagnosing VAP because the specificity and sensitivity are both around 60%. And what is the CPIA score? It's basically a clinical score talking about tracheal secretions where it's abundant or purulent, chest X-ray infiltrates whether they're localized or diffuse, temperature, leukocytosis, leukopenia, PaO2-FiO2 ratio, and microbiology. A score of more than 6 at baseline or after incorporating the gram stain, which is called the CPIS gram, or culture results is suggestive of pneumonia. Now, there are some newer modalities which has come in, which is called the multiplex PCR-based lower respiratory tract biofire, which nowadays we are using for certain patients to diagnose VAP. Again, advantage is that it includes atypical organisms also, although we are not expecting them much as causative agents for VAP at least, but maybe for community-acquired pneumonia. Also, there is, we can see certain viruses, and that may be useful because sometimes we think that there is no viral infection, but when we send, we see that there are certain viral infections which are contributing to the VAP. It also helps to detect the predominant mechanism of acquired resistance because it detects the predominant resistance genes. And this is also useful in VAP with negative cultures to de-escalate or stop therapy. But there are problems of this multiplex PCR-based biofire. The first problem is that you have to really be cautious whether if you are, say, isolating 3 or 4 organisms, which one to treat, you don't know, because even if there is colonization of the respiratory tract, these will show in the biofire. So we don't know whether they are supposed to be treated or not. Second is, we don't know whether the growth of these organisms are particularly significant or not. So that is also something with the microbiologists sometimes can help us with the what are the PCR copies, etc. So we need to really make a very cautious decision before treating the results of these biofire. But it becomes useful in patients where the culture reports come back negative, because sometimes we have started antibiotics, and you have sent the cultures late and the cultures don't grow anything. So if it shows something in these biofire samples, then you can accordingly treat or de-escalate or stop therapy. How do you prevent VAP is also a very important discussion. Now, we all know that aspiration prevention by head of bed elevation is one of the key critical care quality indicators. If you enter a unit and you find everybody's lying flat, that doesn't show a very good nursing quality. So aspiration prevention should be done by head of bed elevation at 45 degrees. Although the recommendation level is low because the studies have been done in very few patients and really not repeated in larger samples. However, it's a harmless activity and most of the time followed. Changing vent settings only if soil, which has got a high recommendation. So we don't change circuits at a regular interval. Sedation interruption and early weaning, these are very, very important and has got a very high recommendation. So every day we need to stop the sedation. Most of the time nowadays we give minimum sedation, mostly analgo sedation, that means analgesia-based sedation. The patient should be conscious but just pain-free. Whenever you want, you should be able to interact, communicate with the patient. The patient should be able to communicate, and that helps in early weaning. More analgesia-based sedation and more more sedation without benzodiazepines or propofol, etc., should be used. Low recommendation for using ultra-thin cuff. Subglottic suction is moderate recommendation, particularly if ventilated for more than 48 hours. In a meta-analysis, the risk ratio was 0.58, but there was no mortality benefit, but there was a trend towards decreasing VAP. There's no recommendation currently for selective digestive decontamination or oral decontamination. There's a low recommendation for saline instillation before suctioning. So most of the time, it's not a great practice to put a lot of saline before you suction. Sometimes nurses do it, but again, the recommendation is very low. Mechanical toothbrush is something which should be considered. It's got a low recommendation, but if possible, we should do mechanical toothbrush, because if the patient is intubated for quite a long time, there is significant colonization of the tooth. The generally not recommended things are silver-coated endotracheal tubes, monitoring the gastric residual volume, stress ulcer prophylaxis. NEJM study 2018 study shows no difference whether you give no difference in instance of VAP, whether you use stress ulcer prophylaxis or not. So maybe this is a recommendation which can be changed for particularly Indian patients, where many of the patients have got a problem with gastric ulcers and peptic ulcer disease, and stress ulcer prophylaxis may be a good thing to do, at least to avoid bleeding. Chlorhexidine mouthwash has got a moderate recommendation, but a recent meta-analysis published in JAMA in 2016 and previously in British Medical Journal 2014, however, unfortunately showed increased mortality. Hence, this is not recommended now. Many patients, even in our hospital, give chlorhexidine mouthwash, but this is not gone. This has gone out of recommendation. And a mechanical toothbrush is probably a better thing to do. Again, inline suctioning is not recommended. It has been shown in quite a few studies to actually increase incidence of infection. The only place where it can be recommended is probably where you do not want to disconnect the circuit that is in ARDS or patients requiring high PEEP, or very infective patients where we do not really want to disconnect the circuit because the patient is going to contaminate the environment. Treatment is obviously IV antibiotics. During discussion on the antibiograms, I have talked about the major antibiotics that are being used, and till now, unfortunately, the backbone has remained as the colistin polymyxin B. We always try to add a second antibiotic to it, either tigecycline, or if tigecycline is used, it should be used in the higher dosage, or minocycline. Carbapenems, most of the time in India doesn't work because their MIC is high. Most of the time, if it's more than 8, it becomes difficult to attain that MIC. The newer BLBLIs like ceftazidime, avibactams, and the rarely used drug sometimes comes to help, as I mentioned, chloramphenicol and cotrimoxazoles, etc. And the rest is kind of sorcery, you know, when nothing is available, you kind of mix this and mix that and hope and pray that patients get better. So it's more of an alchemy or sorcery kind of thing. There's really not much of logic and not much of science, which can be, put into paper. Now, inhaled antibiotics are only used as an additive. It should not be used alone. So that's one thing. There are quite a few things which should be kept in mind while using inhaled antibiotics. The most common inhaled antibiotics used are aminoglycosides and colistin. But again, quite a few things that should be kept in mind. I will not go into the discussion on inhaled antibiotics here. Antifungals, again, there will be a discussion on this, so I will skip this. But there is definitely a role in fungal VAP, post-influenza, post-COVID, immunocompromised host, hospitals with construction work, where the aspergillus incidence and hospital-acquired aspergillosis can increase. Antivirals, again, often detected now in biofire, previously completely missed. But again, it's unclear whether we need to treat them, and most of the time, treatment is not available. So how do you react based on the results? First of all, if cultures are positive and we've started antibiotics and the patient improved with antibiotics, obviously this is VAP and you're going to treat it for 7 to 8 days in general, unless the patients are suffering from very resistant organisms like Acinetobacter, resistant Klebsiella, resistant pan-drug resistant Klebsiellas, and extremely drug-resistant Pseudomonas, where you might need a more prolonged therapy, or maybe the lungs are so badly injured, either because of ARDS or because of chronic lung diseases like COPD and emphysema and ILD and bronchiectasis, etc., that you need a more prolonged antibiotics. And these are situations where procalcitonin may come to help. Again, if the patient improved but the culture negative, then you stop antibiotics, assuming that there may be something, but you have treated for 7 to 8 days and stop it. Patient worsened, culture positive. Again, find out why the antibiotic is not working. Maybe it's not on the right antibiotic, or maybe it is not entering into the right place because of excessive infective load. Maybe there's a pleural effusion which has turned into empyema, and therefore that needs to be drained. Something is happening. We need to find out. Lastly, patient worsened and the culture negative. Again, we need to find out whether it is at all a VAP. So is it the cause of worsening is ARDS? Is it a cryptogenic organizing pneumonia? Is it vasculitis? Is there a pulmonary embolism? Is there drug-induced toxicity, or is there an infection which is not in the lung but outside, was affecting the lung? So there can be a lot of possibilities. Again, we need to know what's growing in our garden, which means we need to know our antibiogram of the hospital, what are the common bugs and what are their usual susceptibilities. And there's an increasing resistance, acquired resistance of tsunami, which is faced by modern medicine. You can see from 2010 to 16, there is a high incidence of OXA48s and VIMs and KPC plus NDM. And the interesting thing is that initially it was just individual genes, either just OXA48 or NDMs or KPC. Now we are getting more of combinations, that is KPC plus NDM, KPC plus OXA48, NDM plus OXA48, etc., which makes things worse. I'll not go into this algorithm. It's kind of this, it's a very complicated algorithm. Again, there's something which was proposed by the Italian physicians. That means when you are treating such resistant infections, keep your backbone as colistin, and then you see if your whether it is colistin sensitive. If it's colistin sensitive, can you add meropenem? That means if the meropenem's MIC is less than 8 or not. If you cannot add meropenem, try to see if you can add TG cycline. If your TG cycline sensitive is less than 1. If you cannot see if you can add phosphomycin, that means if your phosphomycin sensitivity is less than 32. If you cannot see if you can add aminoglycosides or rifampicin, etc., or the other newer BLBLIs which has come up. Again, if the colistin MIC is very high, that means we are dealing with colistin resistant strains, and mostly we see these strains in Klebsiella. Then it'd be very lucky if it's colistin resistance and carbapenem sensitive, and obviously then you'll give carbapenem based therapy. We see it in patient in case where the organism is intrinsically colistin resistant, like I mentioned. That is Elizabeth Kingias and said Providentias and Proteas and stuff like that. Otherwise, again, you'll have to use TG cyclines if the MIC of TG cycline is less than 1, and then again go to 4. So this kind of an algorithm which you may keep in mind, and along with that, you can add the newer BLBLIs like ceftazidime, avibactams. That means if these are sensitive, you can use the newer aminoglycosides which are coming in, the newer glycyl cyclines and the iravacyclines which are coming in, not yet in the market, but will soon come. And there are some siderophore antibiotics which are coming, the cefiderocol, which will again be useful to treat Aspitobacter, and something which probably we are waiting for, although in some centers the reports are not great. But this is a backbone on the basis of which most of the time we treat VAP. I mentioned already about the use of Bactrims, TMP, SMZ, or minocycline, particularly for Stenotrophomonas, Barcholderia, Elizabeth Kingia, Chrysobacterium, and sometimes rarely against Klebsiella in combination. Inhaled antibiotics, these are the ones which are commonly used. Please remember to use a mesh nebulizer. Do not use a jet nebulizer. The mesh nebulizer should be connected near the Y connector, and the inhaled nebulization should be synced with inspiration to make it more useful. Again, treating VAP for physicians in India has become a very difficult game. We have a dwindling number of antibiotics available to us. And as I mentioned many a times, we do a lot of alchemy and sorcery to add this to that and somehow try to keep the patient alive, and most of the times fail as well. So this represents us in trying to treat VAP in the current scenario. We don't know when this whole thing is going to collapse, and we're going to end up in a situation where there'll be nothing left to treat this multi-drug resistant, what should I say? I don't know. It's a multi-drug resistant broth of bacteria that is growing around us. So thank you very much. Unfortunately, since I'm not live, I'll not be able to take your questions, but I'm sending my email. So if you have questions, you can write back to me and I'll try to answer if I know it, obviously. Thank you again. And thanks to all the organizations and Asif for giving me this opportunity to talk. Good evening, good night.
Thank you. Thank you, Chandashis, for wonderful lecture. And I hope tomorrow your lecture will enlighten us. And if there is any query, I will send you message in your chat box.
Sure. Thank you.
Thank you.